Good afternoon, everybody. Dear colleague, I hope that you had a nice lunch today. And after that nice lunch, we hope that we are going to listen to Dr. Walid Kaplan, who is a pediatric consultant, pediatric endocrinologist, and he is the chairman of the pediatric department in Tawan Hospital in Al Ain. Dr. Walid Kaplan is going to deliver a topic of abnormal pediatric thyroid test. I hope that everybody will enjoy with that. Please, Dr. Kaplan.
Assalamu alaikum. Thank you, Dr. Abdul Jabbar. So my job is to keep you awake after lunch. I don't know how many are online with us, but this was supposed to be an interactive session. I think for the sake of time, we will proceed with the questions basically without the feedback for the sake of time. So my main objective is basically to make audience more aware of the normal abnormalities in thyroid function tests in certain settings, and then to enable you to be able to decide when to treat, when to observe, and when not to do anything in children with certain thyroid function abnormalities. Again, I think we're not going to do the polling because this was not set in the audiovisual, but let's see if you guys can guess who has thyroid disease in this picture. So this is George Bush, the father, his wife, Laura Bush, Hillary Clinton, you all know her, and then Bernie Sanders. So Republicans, Democrats. For those who want to guess, I will let you take 5 seconds. And then the answer is actually all of them do. So basically, Republicans have hyperthyroidism, Democrats have hypo, but it's just a coincidence. Anyway, thyroid disease is not something uncommon. You see it in people more commonly than other probably endocrine disorders. So thyroid function test is fairly commonly done by primary care physicians, and they usually do it for common symptoms at clinical presentations such as obesity, constipation, short stature, fatigue, and other symptoms, or sometimes simply because of the request of the family in case of pediatric patients. In one study, it was estimated that 24% of children between the age of 6 months and 16 years had at least one TSH, and in another study, it showed that in a cohort of 1,400 obese children, the yield of thyroid function test is extremely low, less than 0.5% ended up having hypothyroidism out of this cohort with obesity. So you will be lucky when you do thyroid function test if your results fit into the normal definitions or the extremes definitions. So everybody knows when TSH is high, free T4 is low, that's hypothyroidism, needs to be treated. And everybody knows the opposite, when TSH is suppressed and free T4 and or free T3 elevated, that's hyperthyroidism, it should be treated, and then everybody knows that normal is normal. However, in many scenarios, there is a spectrum between normal and abnormal or gray zone, and that's where your thyroid function test end up. And that's when you need to make a decision that can be sometimes debatable between different doctors. So let's run some scenarios. Case 1 is 11 years old female who has weight gain and constipation. Her weight is the 90th percentile and the height is the 80th percentile. She is prepubertal and she has no goiter. Of course, with such presentation, almost everybody will run thyroid function test. So in this particular patient, TSH is 6.9, which is high compared to the reference range showed in the slide. And the free T4 is normal. So what would you do in this patient? Would you do nothing? Would you repeat after 2 weeks? Repeat after 4 months? Or go ahead and start on levothyroxine treatment? I'll give you 5 seconds to think about it. Okay, and the right answer is you should repeat after 4 months, and we will explain why. So this is a subclinical hypothyroidism, which is by definition a condition of slightly elevated TSH with normal free T4 in a patient who has no symptoms at all or has non-thyroid specific symptoms. Again, it's a controversial condition that some physicians treat, some do not treat. Probably in adult endocrinology, this is a treatable condition, unlike the case in pediatric patients. And let me show you why. I'm going to show you 3 studies. They're not very recent. They're like in the 10 years or so. But they're kind of reliable. So the first study is taken from a national insurance registry, and they have followed more than 120,000 children between the age of 6 months and 16 years who happen to have a TSH done on them. So they wanted to see over 5 years period in this very large cohort, number one, what is the relative proportion of abnormal TSH in this cohort? And number two, what is the natural history of this abnormal TSH? And then they wanted to conclude if there are any risk factors that can help in the future, knowing which patient should be treated and which should not be treated. So out of the 120,000 or 121,000, 96.5% ended up having normal TSH. So the abnormal was only 3.5%. Again, another strong evidence to show that we're overdoing thyroid function test, and the yield back is really, really low. And out of the 3.5% abnormalities, 2.9% had a TSH in the range of 5 to 10 with a normal free T4, and that's basically subclinical hypothyroidism, and less than 1% ended up having an overt hypothyroidism or hyperthyroidism. So out of the 1,226 patients with clearly hypothyroidism, they were treated. I think this is a no-brainer decision. Similarly, 49 patients with hyperthyroidism, those were treated as well. This leaves us with almost 119,000 patients who did not fit into those, and those who had slightly elevated TSH, normal free T4. 64,500 patients had no further TSH, so they could not tell about the trend or the outcome, but they still have a very good number of 55,000 patients who had a subsequent TSH, and let's see what happened with those patients. Again, this is the ones with the slightly elevated TSH between 5 to less than 10 and normal free T4. Again, we're not going to talk about the hypothyroidism, we're not going to be talking about the hyperthyroidism, and we're not going to be talking about those who had normal TSH, and I have no idea why they repeated the test. And that's, again, probably a take-home message. If you test your patients and thyroid function test is normal and clinically there is nothing, do not repeat the test. Please do not repeat unless there is clinical justification. So we need to focus on this group. This is the group with a TSH between 5.5 to less than 10. They repeated the TSH. What was the outcome? 73% of them had normal TSH within the follow-up period. 25% of them had no change. They continued in the range of subclinical hypothyroidism, and only 2% ended up having TSH above 10, no abnormality in thyroid hormone level. So those are the only fraction in the follow-up that had their TSH worsened. Over 5 years period, what happened with this cohort, 8.5% of them ended up being treated, which means more than 90% did not need any treatment over 5 years period. And the predictive factor that they concluded from that study, that if the initial TSH was more than 7.5 and the patient is a female, those were the correlating factor to indicate more likelihood of needing treatment. But keep in mind, those who needed treatment were less than 10%. Another study, much smaller cohort, but it's a prospective study. So this is 92 patients aged between 5 and 15 years, who had also slightly elevated TSH with normal free T4. Those patients had no goiter. They were healthy. They were not on medication that interfere with thyroid function test. They had negative antibody. And furthermore, they even did ultrasound on them to confirm that the thyroid ultrasound is normal. So those are purely normal children with the isolated finding of slightly elevated TSH. And they wanted to see no treatment on them. Let's see what's going to happen with them at 6 months, 12 months, and 24 months. So 41% of those patients had normal TSH, 40% of those between 6 to 12 months, 60% in the second year of follow-up. No one normalized TSH before 6 months of follow-up. 48% did not have any change. So once again, we have an 89% of either normalized or continued in the same category, and 11% had a TSH above 10. And there was no difference in this cohort at presentation to see if there is any risk factor or correlating factor. Same level of TSH, same level of free T4, and same level of clinical presentation. So they could not conclude who in the future might end up being of those 11% and who can be of the other 89%. So basically, they said about 10% of the patient had deteriorated course with the increased TSH above 10. There was no cases of overt hypothyroidism, in another meaning high TSH and low free T4. And they say that the normalizations might take more than a few months, so they have recommended not to do a follow-up on your patients in a month or 2 or 3. Just make it 4 to 6 months. This is a meta-analysis of 9 studies. Not all of them are purely subclinical hyperthyroidism. Some of them have autoimmune thyroiditis as well, but they all showed about the same percentage, 10 to 12% of patients who have worsened TSH to increase above 10 international unit per liter. And in this particular meta-analysis, they have concluded that female gender, positive antibodies, presenting with goiter, and positive family history basically are factors that might indicate needing treatment because of increased TSH. So summary number 1, subclinical hypothyroidism is a slightly elevated TSH with a normal free T4 in asymptomatic patients. Those patients can be treated only if the TSH goes above 10, or if TSH around the 8 or so, but stays as such for more than 6 months, in a female patients who have positive antibodies. Outside those, you do not need to treat your patients. Case number 2 is a 10-days-old male referred to your clinic if you're pediatricians because of abnormal newborn screening for the thyroid. It's a full term, no prenatal complications. And of course, once you have those patients with the abnormal newborn screening, I mean a heel prick sample, you need to repeat that by doing venous sample to confirm the abnormality. So you did that in your clinic, you did it venous, and your thyroid function test showed a TSH of 11.6. Normal is up to 6, so this is clearly elevated. And a free T4 is normal of 15. So what are you going to do here? Start on treatment, refer to pediatric endocrinologist, repeat the test after 2 weeks, repeat the test after 2 months. Again, I'm going to give you 5 seconds to think about it. All right, and the answer is you have to repeat after 2 weeks, and let me show you why. First of all, TSH in newborns and in the first month of life is absolutely not like TSH in older patients. So again, I'm showing this in 2 slides from 2 reference labs. If you are doing a TSH on your infant in a lab that does not have reference range for the first month of age, do not use that lab. Otherwise, you will not be able to interpret the data. You cannot match your TSH of a 1-week-old or a 2-week-old with a TSH of 25-year-old healthy adult. So once again, you see that TSH start high, postnatally, drop gradually in the first month, sharply rather, and then drops slowly to reach the adult value later on. The European Society for Pediatric Endocrinology, along with the Pediatric Endocrine Society of North America and the Japanese Society of Pediatric Endocrinology, almost every pediatric endocrinology society have basically come up with a guideline for congenital hypothyroidism in 2014. What you need to do from the guideline is those who need treatment fit into 3 categories. A capillary TSH more than 40, that means on a heel break, newborn screening. A venous TSH of 20 or more, regardless of the free T4, or free T4 is low, regardless of TSH. 3 categories you treat based on these without anything else. What if your patient has a TSH above 6, but it is below 20, where you need to treat? Those are the cases similar to the one I have presented. You can follow up to 3 weeks and then do further investigation if it continues to be abnormal, such as thyroid scan. You can initiate treatment, or you can do one more follow-up in 1 to 2 weeks, and if it is abnormal, then you need to treat. And those patients can be treated basically prophylactically until they reach the age of 3 years. And you can tell from the course of their illness over the years whether if the dose is increasing, TSH is going up, they will need it for probably longer time, versus if the TSH is going down and the requirement of treatment is dropping, then those would be probably the ones who can be weaned off the treatment. So back to the case that I presented, it's a 10 days old and TSH in the range of 6 to 20. So basically you can repeat after 2 weeks. You can refer to pediatric endocrinology if you don't feel comfortable, but again, if this case ends up being normal, this is unnecessary referral. Case number 3, 4 years old female, admitted to the ICU because of sepsis, and she had a normal TSH, but the free T4, free T3 are both low. Do you do nothing? Do you treat? Do you repeat after 3 days? Or you repeat after 3 weeks? And the answer here is you repeat after 3 weeks. So this is euthyroid 6 syndrome. What happens during illness? The conversion of T4 to T3 is basically inhibited. Conversion of T4 to the inactive or reverse T3 is stimulated. If you lived 30 years ago, most of the lab used to measure reverse T3. So usually in those patients, the T3 will be low and the reverse T3 would be high, and you confirm a diagnosis. But now you make it because of the clinical course, because you cannot do the reverse T3. And this is what happens during illness. TSH is slightly high, reverse T3 is clearly high, while T3 and T4 are dropped, and during recovery, everything is normalized. You do not need to treat. However, I don't recommend that you do this to start with during acute illness, unless you really have to. If your patient is hemodynamically unstable, probably you can consider that. Other than that, you don't do it, but if you did it, then you can repeat after 2 to 4 weeks. And my last case is a 13-year-old female presented with goiter, normal growth and puberty. She had slightly high TSH, normal free T4, and positive anti-thyroid antibodies. Again, slightly high TSH, positive antibodies, and this patient has goiter. What do you do next? Observation, repeat after 3 months, order ultrasound, or treatment. And treatment is probably the most appropriate, even though this is highly debatable because some might recommend to do follow-up in 3 months. Why is this? Autoimmune thyroiditis is the most common thyroid disorder in children, and the majority of cases do present with goiter and either normal thyroid function test or subclinical hypothyroidism, means TSH is slightly elevated, but there is positive antibodies here. Rarely hypothyroidism. So unfortunately, they don't present with a clear picture. And then the treatment should be given for those with low free T4 or with goiter. So in summary, thyroid function test can be normal. Thyroid function can be normal even if the thyroid test is abnormal. Examples that I have shown you in these cases during acute illness, or if you're not using the age-matched reference, or if you have partial abnormality of thyroid function test. Follow-up testing is very helpful, and treatment, and or referral should be only selective for certain cases. Thank you so much.
Thank you very much, Dr. Jamal. It was excellent.